Hi, I'm Bob Comator from the law firm of Levy, Phillips & Koenigsberg, and we're very pleased to have with us today Dr. Harvey Pass, the Chief of Thoracic Surgery at NYU Medical Center and a specialist in mesothelioma and lung cancer. Dr. Pass is a Phi Beta Kappa graduate of Johns Hopkins University and Duke Medical School, and he's devoted his career to treating thoracic malignancies, including lung cancer and mesothelioma. Dr. Pass was appointed head of thoracic oncology for the National Cancer Institute in 1986 and held that position for 10 years. During his tenure, among other accomplishments, he developed one of the first organized prospective tissue archives with accurate matching demographics and used this resource to begin a series of ongoing collaborative studies of the molecular biology of mesothelioma. Dr. Pass has been the director of the NYU Division of Thoracic Surgery since 2005. His laboratory is the home of the National Cancer Institute-funded Early Detection Research Biomarker Laboratory for Mesothelioma and the clinical core for the NCI's recently funded Mesothelioma Pathogenesis Program project. He is a vigorous advocate for patients with lung cancer and mesothelioma, serving as a Lung Cancer Alliance board member and chairman of the Scientific Advisory Board for the Mesothelioma Applied Research Foundation, otherwise known as MARF. Dr. Pass is the author of many articles and books on mesothelioma, including 100 Questions and Answers about Mesothelioma, a very important guide for folks who are trying to decide what to do once they're diagnosed with this devastating disease. Dr. Pass, we're very happy to have you here today.
Hey, Bob.
I know you've been involved for many years now with research on mesothelioma. Why don't you tell everybody about some of the more recent developments that you've been involved in?
Well, everybody, the holy grail with mesothelioma now is to either define patient groups, how to find patients early, or to find patients who will respond to certain drugs, or to find patients who you know really shouldn't get operated on because their prognosis is different. So we've been very active in trying to figure out if somebody has an asbestos exposure, are they at risk, and will give us some signal in the blood that they're developing a mesothelioma. So we have a series of markers that we've looked at that are in the serum and the plasma of patients, some of which we've published, that look very promising. And we've actually validated some of those. One of those includes SMRP, which is the most common one, that now is available as a approved test in a reference laboratory. Osteopontin still is being looked at, and specifically in the plasma. And then there are other biomarkers that are coming out shortly that are even better, that have the chance of really discriminating between mesothelioma and other tumors, as well as finding the disease earlier in patients who are asbestos exposed. We feel that if you find the disease early, everything improves, that you'll be able to do less of an operation, that you'll have a greater bang for your buck if you give some sort of cytotoxic therapy.
So when you say early, you're really talking about well before any symptomology, because I know when it comes to people that I know who have mesothelioma, usually they don't know even to go to a doctor until they have the symptoms, and at that point already it may be getting to be too late.
That's right. I mean, the whole way to look at this is most people, as you know, present with some sort of pleural effusion, but that pleural effusion has been there a while. So if you have a marker or a series of markers that work in concert to say, this patient who has no symptoms that comes into your office, if you get this blood test and the blood test says this patient has an effusion and the patient doesn't even know it, then that would be the first thing to say, hey, we need to get a chest x-ray to at least document whether there's an effusion. And if there's an effusion, then there's a series of markers that you could look at to even see whether that effusion is meso or not. But the presence of an effusion in an asbestos-exposed individual is a real cautionary sign. So that wouldn't mitigate a workup.
And that really sounds like it's really not even all that invasive to be doing.
Absolutely. I mean, that's the whole point. You need to do something that's going to be cost-effective as well as minimally invasive. A CT scan is not that cost effective, and also it hasn't proved to be the way to go in meso. In lung cancer, yes, at this point, but not in meso. And you want to make it so that it's easy for the patient. The patient gets a blood test, or maybe even gets like a diabetic test, so it's a real small pinprick, and you can do multiple markers on it. That's what we're trying to do with these markers.
Now, I know you've also been involved in developing a tissue bank for mesothelioma and looking at when you can, getting actual mesothelioma tissue. How does that help in advancing your research?
There's only 2,500 of these unfortunate people in the country. Over the world, there's a lot more, but every patient is golden, because we not only have an obligation to treat the patients, but we have to figure out what to do about the disease. So every patient that comes to see me with mesothelioma, even if I just consult on the patient and the patient is going to be treated elsewhere, we ask the patient to participate in our biomarker program. The biomarker program is as simple as we ask them to give us blood, and from the blood we can look at the biomarkers that I just talked about, because there's two components of blood, serum and plasma. We can look at their white blood cells if they give us permission to look for genetic changes that may be inherited. We can look also, believe it or not, at RNA and DNA in the blood too. So that's a rich resource that is not just from my lab, but we do this to share with other labs also. In fact, we're part of the National Mesothelioma Virtual Bank, which is funded by the CDC for this very purpose, and it includes Mount Sinai, University of Pennsylvania, NYU, and University of Pittsburgh, that's the PI, where we put our banks in a virtual way open to the mesothelioma community, so that people can ask for the specimens with a protocol and we'll approve it, and then they'll get the specimens. So when I operate on a patient, I ask the patients, can I please have a portion of your tumor, and if I'm going to actually do an extrapleural pneumonectomy, I will also take normal tissue, because it's important to know the differences between the tumor and the normal. Normal meaning that mesothelium, that target of injury. Why did that happen to that mesothelium? So what's normal, and what are the patterns of genes or proteins in the normal versus the pattern of genes and proteins in the tumor? And by looking at those differences, we may find ideas of what's different, what's in the blood that we could look for, as well as what we can target. So by having that tissue, there's a series of important platforms. What's a platform? You can either look at genes or proteins or sugars or antibodies, but if you have the tissue and the material, somebody who's smarter than you are, who has a new platform that really needs to be validated, wants to do it in meso, you just send the stuff to them so that they can start working on it. And that way they can get funded, hopefully, through the United States government, through the NCI, to be able to have money to do it.
And again, when we're talking about those kind of people, they're looking for drugs or some kind of chemotherapeutic agents that, once they have the genetic basis or plasma basis to find out how to target those things, they can then try to find the right
drug. Mesothelioma is no different. The goals of treating mesothelioma are no different than the goals of treating breast cancer or lung cancer or pediatric malignancies. We want to find something that is specific to a patient. Just with the revolution of specific targeted mutations and changes in the DNA content of tumors in lung cancer and breast cancer and colon cancer, we want to do that in mesothelioma, so that if a patient presents with a mesothelioma, you could do a biopsy or something from the blood that then gets analyzed. It says, oh, this patient has this problem with their gene, with this gene, or with this protein, and we have a drug that specifically targets that gene or that protein, and then you can study whether that interferes with some bad pathway or interaction of the drugs, or the genes and the proteins, so that you have personalized treatment for that patient.
Now, this may be a tough question, but why do you think mesothelioma is so hard to find a cure for?
Well, I think that there's a number of issues. I think it is a rare tumor, so there are not many individuals who really concentrate on the disease. I concentrate on mesothelioma, but also concentrate on lung cancer. I also have access to tissue on both, so it makes it easier for me. Second, it's not that type of tumor that really is out there. Breast cancer obviously has a tremendous advocacy group, has always had an advocacy group. We have MARF, and they do such a great job. But even for 2,500 people, one organization, it would be nice to have others. But MARF does an incredible job. Finally, if you have something that's only 2,500 and you don't have a lot of investigators, then you can't get the resources from the federal government with regard to research dollars to be able to do the type of research that needs to be done. It's getting better. It's getting better through the advocacy of MARF. It's getting better through the advocacy of...
MARF, for those who don't know the acronym, is the Meso Foundation, or
Correct.
Mesothelioma Foundation.
And to be able to have organizations such as the Department of Defense that now has targeted money for it is terrific and is novel and absolutely tremendous. But if you compare the amount of funding that's for that disease and the amount of dollars that it costs with regard to all the other things that you're involved with, you know, if we found a way to cure the disease, if we spent the money in the right direction, either find the disease earlier, all those late costs of caring for the patients that cost so much when it's late stage disease would be then converted to maybe minimizing the disease in early stages so that the patients would live longer, and it becomes a disease of chronic illness, so that you keep the patients in a steady state without the disease advancing. That's going to save money in the long run. It's just a matter that it's very difficult to convince certain organizations of the importance of that.
Yes, and because of the limited number of people that have the disease, I think that's part of the problem. The Department of Defense you raise is a good source, because a lot of people who served in the military, in the Navy, were exposed to asbestos, and so a lot of veterans do come down with this disease because of just what they did in the Navy and so forth. And so the Department of Defense is a perfect source of funding. One would not expect it, but that's a perfect source.
Absolutely, and I must admit though that there is a change in the wind. In other words, okay, who are the other people that really are at risk? Well, it's the hard-working laborers that are plumbers, insulators, electricians, the people who do the jobs that our life, it makes it easy, but they're represented by unions. And what is very gratifying is that unions now are very attuned to the risk of this. Unions are now becoming more interested in devoting resources to be able to look to having their groups that they represent participate in the sort of research that's necessary to find, say, the disease earlier. And so that's another, it's almost like a volunteerism of the unions that is needed. It goes along with the idea of philanthropy. That's very important for this disease also.
Yep.
And so any source of funding that then can be shared among investigators, which is another problem. The ability to get investigators to work together so that you can share tissue, somebody can be researching this aspect of it, this aspect, and it's all the same tissue.
Well, that's the beauty of the tissue bank and that.
So that you can all work together, and that's slowly coming around. People are now putting in what's called SPOREs, special programs of research excellence, that's from the National Cancer Institute, for mesothelioma, which is terrific, in which you have institutions working together trying to use the resources from the NCI as well as from their own universities to try to find how to solve this disease.
Well, I know that, you know, again, there are folks like you who are doing this research, and there aren't that many, and again, there is MARF. We've contributed both to MARF and to your research, and how can people, if they want to contribute to your research and what you're doing, how would they go about doing that?
Well, it doesn't have to be just to my research. I mean, there are other investigators besides Harvey Pass that are doing really top-flight research in mesothelioma. I think it's very important. You would not go and buy a car from the first person who talks to you about a car. So for somebody who's interested in making an investment for research in mesothelioma, they should get consultation as to where are the centers that are really doing the type of research. They could go to MARF, they could find out what it is, and then they could study what's happening. They could call the investigator and say, I've heard about this, can you tell me about this? And then it's a targeted contribution that they want to make. But I think we need more of that, and I think it's important also that people who do engage in philanthropy like this, they're the boss. And if they insist that I'm giving you this money, you researcher, but I want you to use this money with other people so that your research is amplified because somebody else is working with you from another place to be able to do this. And that's where synergy comes together. So it's not just my research, and believe me, it's important for philanthropy for my research besides the grants that I have. But you should do due diligence, and if you're willing to do that, find out who the researchers are and investigate it.
It's excellent advice. Last question: can you tell us about any exciting research or developments on the horizon that you see happening?
Yeah, within the next year, I think that there's going to be a marker that's published that is one of the best markers that's out there. I think that needs validation, but it's a novel finding. I also think that other laboratories are working on looking at every mutation in the genome of mesothelioma. I think that's a very important exercise because by doing that, just like we're doing in lung cancer and in other tumors sponsored by the National Cancer Institute, if you find a mutation that is novel to mesothelioma, or if you find a mutation in mesothelioma that, say, is in lung cancer, but there's a drug in lung cancer, then you should use it in mesothelioma, as crazy as that sounds. So then you can get these profiles of individual mutations, and if you have drugs that target those mutations, or you could start developing drugs to target that mutation, within 2 years, then you can define on a personal basis, this patient needs to get this, the studies are launched to be able to see whether you respond. I think that's one of the most exciting aspects of mesothelioma research for therapy. I also think that there are a lot of other novel things that are being done. I mean, we never thought that animals mean that much with mesothelioma. There are a number of great animal models that are being used to study the disease, but animals are also being used on a personal basis by certain institutions where if somebody gets operated on, the tumor could actually be implanted into animals. If the patient has early-ish disease, then if that tumor graft then proliferates and you're able to expand it into a number of different animals, then at the end of the day, in 3 or 4 months, you have a lot of animals. You could try different cocktails of treatments to see whether actually the animals do respond to a good one. So we know about mesothelioma. We know we have to be worried about it coming back. There are patients that then could go back to see how the animals responded, and you could use those drugs when they recur. That's way out there.
Yeah, that's
ideas that some people are doing that we'll see whether it actually pans out, but it's not for everybody. So I think there are I think there are more than a couple of exciting developments. The key thing is we can't be redundant. We have to work together, and we have to then validate everything that we find.
Very, very interesting, and I hope folks have found it as enlightening as I have. And I'd love to have you back in maybe 6 months, and we'll talk about whether any of these things are coming closer to fruition.
Happy
but
to
I
do
thank
it.
you very much, Dr. Pass, for being with us.
Thanks, Bob.
Thank you.